Good afternoon, all. I thank the organizers for inviting me here. So, from ISN Menger to the fetal interventions. So, cardiac interventions in pregnancy. We'll talk about the feasibility and the applications. To start, I just show my gratitude to Professor Savitri Srivastav, who have taught me this fetal echo and shown me the interest in this field of cardiology. So intervention, why this fetal intervention? Because cardiac development, as we know, it starts by 8 weeks, and we can identify a congenital heart disease as early as 12 weeks. The primary morphological changes in the heart during the fetal period, like the valvular lesions and all, they affect the heart function and the size of the heart, the secondary changes in the heart, and which cause the ventricular hypoplasia. So the early intervention during this fetal period can change their outcome to be a single ventricle versus a biventricular heart. And that's how this idea had come of a fetal intervention. So this is the operative branch of the fetal medicine where we deal with the sick fetus and the aim of achieving a fetal well-being, and it includes medical, catheter, and surgical procedures. There is an international fetal cardiac interventional registry where we see, if we see the world picture, the most of the countries who are doing regular fetal cardiac interventions are concentrated in US and European countries. So the fetal cardiac intervention, registry, they had published a paper in 2019 where they did combined all their interventions, the fetal cardiac intervention in aortic stenosis and aortic atresia, and the report shows that out of 700, the 452 were suitable for intervention, and there they have found the maximum interventions were being done for aortic valvuloplasty, and it was followed by the atrial septoplasty or stent and pulmonary valvuloplasty. There were some other indications like heart blocks and other things. So the result which they published was very interesting. It showed that the fetal loss was only 11%. There was no much maternal death or major complications, which shows that these interventions, if it is indicated for the fetus, is otherwise safe for the mother. The preterm delivery was around 24%, but the survival to discharge was 67%. The results were quite promising, and we see there is another data which also shows that in this group of patients where there was aortic valvoplasty, and some of them which had associated restrictive ASD or intact septum also, that the success rate was around 50%. The mortality was around 25% only. Though ultimately the mortality did not differ between the intervention and non-intervention, but there was a significant difference with those who had successful intervention, that they had led to a live delivery and mostly a biventricular repair, which was actually phenomenal data. The variable which was strongly associated in this study was the restrictive atrial septum. So if the atrial septum was restrictive or the intact, the results were otherwise not so good. So if we compare our country, we have also started our interventions, and Dr. Nageshwar Rao is here. He was the first to do the intervention, and also in Kochi. So the centers are much less, the need is much more. So if we want to know about the feasibility, yes, definitely there is a potential benefit to the intervention. The revolutionary change in the outcome if it is successful. So procedure, even if it is with risk, and there is a challenge in counseling and financial issues, we should go ahead. The first intervention was done for a patient of fetal VT as early as 1975, where propranolol was given. Then their first cardiac pacing was done, which also had good advancement over the years, and the balloon dilatation as early as 1991. So this was the paper where Allen, Sherland, and Tynan, as early as 1989, they only focused on the fact that the natural history of hypoplastic left heart, which they observed, that the babies are as early as 22 weeks gestation, when there is aortic valve stenosis, but the mitral valve is small, the left ventricle starts getting hypertrophied and dilated. And over the weeks, actually the left ventricle becomes more echogenic, and becomes a hypoplastic left ventricle. So if we have to change this scenario, that we have to intervene at this period when the aortic valve opening can be opened or the atrial septum can be widened so that the outcome can be. And they had two there. And they had two cases of ballooning, and I just found out from Dr. Shak, that they are doing okay. One of them is actually doing okay after this ballooning. The fetal interventions, if we see the fetal medicine people, they do a lot of interventions. The twin-to-twin transfusions with fetal anemia, with the congenital cystic adenomas malformations, they do some the pediatric surgeries are also being done. If there is a massive pericardial effusion for any reason or associated with hydrops, there is an option for pericardiocentesis. And then in structural heart disease, to talk about the today's topic, there is the option of doing an aortic valvoplasty in critical aortic valve obstruction or a pulmonary outlet obstruction. We can go for a pulmonary valvoplasty in those subset of patients where there is a definite indication. In the field of arrhythmia also, in some of the arrhythmias where use of medicines to the mother doesn't help, there is ventricular dysfunction and hydrops. There can be transplacental introduction of this antiarrhythmic drug or directly fetal intramuscular injections of digoxin and other medications. Similarly, in complete heart block, we have also seen the transplacental pacing is being done, and there are good outcomes with the newer devices of single pacemakers. Also, in myocardial diseases, the use of IVIG can be done. So the recommendation as the registry has given in 2014, it says that it is a type 2B indication when the diseases are such that it is disease modifying. And if we find on the echocardiography that there is retrograde flow in the transverse arch, severe LV dysfunction, if there is a monophasic or short mitral valve inflow, and if there is left to right shunt or restricted flow across the PFO. And also in case of intact atrial septum, definitely the indication becomes more strong. Also in pulmonary atresia and intact ventricular septum, it is wise to do a pulmonary valvuloplasty if to get these children go into biventricular repair. So the fetal therapy in India, as the Hyderabad Center has done, there were cases of pulmonary aortic intramuscular digoxin, pericardiocentesis, and IVIG, and Amrita also. We had done only one case of pericardiocentesis. So if we just go through the fetal, the overview of the valvuloplasty, we see that it is a teamwork. It's not that only a cardiologist, it is a group work with the obstetrician, the radiologist, the anesthetist, and fetal position is very important to start this. And after proper counseling to the parents, definitely fetal anesthesia, and then we can use the needle 21G and the 18G for 21G for the anesthesia and the needle, and then go for the balloon. So this is how it is being done between 21 to 32 weeks under maternal local anesthesia and sedation. And as I already told, the fetal position is very important for the procedural success. Through the maternal, the aortic valve is crossed and the balloon is placed and it is dilated. So this was a fetus of 22 weeks where the mitral valve Z score was less than -2, and gradually over 32 weeks it became much smaller. And in further advancement, we saw that the left ventricle becomes very echogenic and becomes hypoplastic if not treated. So these were taken from the Western papers, that after their balloon dilatation, they demonstrated that there was antegrade flow, though in some of their cases, there were also reports of aortic regurgitation, which we should be aware of, but the function definitely improved. There are also case reports of transuterine technique, the fetal aortic valvuloplasty, as we see here in the picture, after opening the mother's abdomen. If we go to the results, the Boston data by Troitsky, it's shown that out of 84, there were 72 live-born and technically successful 69 cases, and their deaths were only deaths were 3 and 19. So the survival rate is around 50%, which is actually quite promising, and most of these babies going for the biventricular repair afterwards. Another in that study, we also saw that some of these cases which were in bidirectional glen in the initial phase would also be converted to the biventricular repair. So which is a phenomenal study.
Can you summarize?
Yes. So the Boston study also showed that the survival was 50% at 30 days. Nowadays, they are using transesophageal echo to have better picture and more procedural success for their things. Here we can clearly see the thickened atrial septum, where they are trying to poke through the atrial septum and could not wire could not pass. So this is another scenario of pericardial effusion with the high drops, where we can do a pericardiocentesis. The right ventricular obstruction causes severe tear and the right ventricular dysfunction. So there is a chance of, there is a scope of pulmonary valvotomy in these cases. And here this study also shows that most of them were live born after the repair, and most of them had a biventricular repair. Same reports also reported by Lynch from the London experience. So they predicted that if
Dr.
the
Manisha,
tricuspid...
can you just summarize?
Yes, it's almost done.
Okay.
Predicted the tricuspid to mitral valve ratio, the RVLV length, which gave and the inflow duration and the presence of sinusoids, which gave the sensitivity of 100% for the procedure to be successful. The other aspect I said, the tachyarrhythmias, where in VT, SVT, we can give intramuscular digoxin to the fetus or transplacental injection of the drugs. Also in CHB, the role of pacemakers. So to conclude, fetal cardiac intervention is definitely feasible and very challenging. The techniques and the hardware research will help in improving our results. Follow-up of this group is very interesting to be followed up, and the future directions lie on the technical advancements like the computer-assisted navigation, open fetal cardiac surgery, and the fetoscopic cardiac surgery. They are into process these days. Thank you.